All right, Felisa, you made it. Welcome. Do you want to kick us off or would you like me to?
I'm happy to kick us off. So first of all, I want to thank everyone for being here. I'm in a little bit of a precarious situation, so I'm not super able to see all of the folks. So I'm going to do my best to kind of go through participants and help facilitate the meeting. So I think the first thing we want to do is go through who is here. And so I feel like, Sarah, actually, could you run through that if that's okay?
I can definitely do that. Let me go down the roster. I know a number of people have let me know that they're not able to make it today. So Michael Anderson Nathy is not available today. Morgan is on and having connection issues, so she's here. Melissa's here. Peter is here. Angela, are you here?
I am.
Great. Angela's here. Ivy's here. Lawrence is here. Maybe going to go off camera, but here. Maribeth, are you here? Looks like no Maribeth yet. Felisa, you're here. Jason. No Jason. Okay, I don't see Jason. Jim.
Present.
Welcome. Herdesh.
Yeah, I'm here.
Great. Teresa. I don't think I see Teresa either. Okay, no Teresa. Stefan?
Yes, I'm here.
Great. Gil Munoz is not here, but Charles is sitting in for Gil. And Charles, I think I saw you join. Yes?
I'm here. Good afternoon.
Great, thank you. Nick?
I'm here.
Shannon Saldivar is not available for today's meeting, and Karis is also not available for today's meeting. Greg?
Present.
Julie?
Yep, I'm here.
Julie is here. Great. Okay, and then our ex officio members, Andrew Stolfi is not available, but Jesse O'Brien from DCBS is sitting in. And I didn't see, do we have Pat Allen? It's like Pat is not on. We've got Jeremy and Dave. We'll call that our OHA representation for today. All right, I think that is our roll call.
Okay, thank you. So I appreciate everybody who was able to make it today. I do want to remind folks, especially because I'm in this precarious situation, that as we go through, it would be helpful if folks could use the raise their hand feature to jump into the queue. That way we can see who's lined up when we are talking. And it will help me facilitate the first part of this meeting. And I think the next thing on our agenda is our co-chair update, which is incredibly exciting, that Peter Davidson has agreed to be the co-chair. So we could all give Peter a hand for stepping up. And if Peter, if there's something you'd like to say, please feel free to jump in now.
Just happy to work with the whole team here and to try to figure our way through this in a time of unprecedented inflation. So it will be an interesting process.
Okay, great. So the next thing I just want to do is a July meeting minute summary was sent out to folks on the call and via Zoom. If there are corrections or changes that people would, any clarifications needed, please jump in and get those out there now for the staff. Okay, I'm not seeing anybody. I don't want to act like this is your last time to ask questions about the July meeting, obviously. So if you do have questions, obviously, please feel free to circle back. And if you have corrections, you can put them in the chat as we go along, or reach out to Sarah at the end of the meeting. So I think for today, we want to run through an agenda review. So the first thing we'll want to start with is a discussion where we left off from our last meeting on value-based payments. And oh, I'm sorry, actually, we want to do program updates. Then the first discussion item we have will be a value-based payments compact and work group. And then we're going to do a deeper dive on the pharmacy cost issue, which I think was a big part of our conversation and a lot of questions from the last meeting. Are there any comments or additions or changes to that agenda? I'm going to be honest, I don't think I should ask you guys if there are changes to the agenda. The staff actually might murder me, which they would have every right to do. But I do want to leave it open. If you do have some, please jump in. Okay, let's get started with program updates. Sarah?
Okay, I think the first program update that we want to give, I think most people are aware at this point that Jeremy Vandehey is leaving OHA in the next couple of weeks. And I think because he has been so involved in the cost growth target work from the beginning and been just such a champion for this program and working so closely with this committee and the predecessor committee, I think we wanted to just pause for a minute and recognize what a loss this is going to be. And also, Jeremy, if you would like to share any reflections with the committee or parting words, that would be great.
Yeah, thanks, Sarah. And apologies, I've been sick with my first bout of COVID this week. It finally caught me. So sorry, I'm a little stuffed up. So I just, I kind of, well, I guess we'll reiterate some things I said at the first meeting, which is just that, we've spent a lot of time building this. It started back in 2017 with a discussion around hospital rate setting and how that wasn't the right direction to go as a state, and that we really needed to focus on total cost of care. And I think that we've had strong commitment from across the industry and non-industry and consumer advocates to really build this up as a sort of pillar of where we head next for health reform in the state. I think, as Peter said, there's going to be, there's obviously no shortage of challenges right now within the health system or within the economy. And I think that it's really, I think it's really going to be interesting for you all to think about where this program goes next and how we really utilize it in terms of actually getting to affordability within the state. And just wanted folks to remember the amount of work that has gone into building this over the last 5 years and standing it up, and the amount of commitment. And I think I may have said this at a couple of meetings ago. I've had legislators ask me, well, how do we know this is really going to work? What if it's not going to really work? And my answer has always been, look, if we don't meet the 3.4% target, the whole goal of this is to understand why and where the problems are, and to bring data back to the legislature in terms of where the problems are and where the potential solutions are. And I hope that everybody really holds to that as we go into some tough times within the economy and within the healthcare system. And I really look forward to seeing where you all take this program, and just want to say huge thanks to Felisa and Peter for stepping up into the co-chair roles, and huge thanks to Sarah and Bayla and team and others who have just done a tremendous amount of work standing this up over the last several years to build for the role around the policy board. So I feel like this is, let the ship sail at this point. And, just to really appreciate everybody's commitment to this, and we'll be sitting in a different seat, but look forward to seeing where this goes in terms of the next wave of health reform. And again, just want to thank everybody for your commitment to step into to this committee and to keep moving this work forward.
Any comments or words for Jeremy that anyone wants to share before we move on?
Well, I'm happy to jump in here. I think that I personally have really benefited, and our state has benefited greatly from the work that Jeremy has done at OHA. And the big projects that he has helped to shepherd through. He's been a real leader in the transforming of healthcare, and a big leader in this endeavor on cost growth. And I think, you're moving to a different seat in healthcare, but we hope that we can, continue that long-term partnership and that commitment to moving our state forward. And I know that they are incredibly lucky to have you. It'll be a devastating loss for OHA, but we're all looking forward to working with you in the future.
Thanks so much, Felisa.
Are there others who'd like to add anything? I know lots of folks have worked with Jeremy for a long time. By the way, this is not a public comment space, but other folks on the board.
I'll just say briefly, similar to what I said at the Oregon Health Policy Board meeting earlier this week, Jeremy, we really appreciate all the work you've done. We know you are a central contributor to this particular effort on the cost growth target. And I think you've helped this initiative to get off to a really good start, and appreciate all that you've done, and wish you the best in the next stage of your career. Hope you can stay involved in these issues going forward.
Thanks so much, Bill.
All right. I think if anyone has other messages for Jeremy, please feel free to leave them in the chat and we'll keep going with our agenda if that's okay. All right. Thank you. Durandi, let's go ahead a couple of slides to program updates. One more. There we go. Okay. So our first item for you today is following up on the questions from the July meeting. So if you remember the July meeting, there were lots of questions and requests for more information. And while I think we're pretty nervous about just always answering every question that you come up with, we felt like a lot of the questions that were raised were really reasonable and appropriate and really help further the discussion. So we have some more information for you. So generally the questions and requests that came up in July, we can group them into 3 categories. So the first is things that we're going to keep talking about more today. So there were some questions about BBP, that will be our next agenda item. There were questions about pharmacy, that's going to be a significant portion of the rest of the meeting. There were some questions that were more just a follow-up. We need a little bit more detail, or what do we know about X? And we provided a number of handouts for you. There were a lot of meeting materials for today. Not again, necessarily that you were going to read them all, but some of those follow-up questions are directly addressed in those additional documents that we provided. And then the third category, some of your questions were pretty complicated and they need a little more development. So things like, how are we exactly going to measure behavioral health spending? We have a primary care spending definition in Oregon. We do not have a standardized behavioral health spending definition. We probably need to do some more work before we're ready to start churning out data on that. So some of this is going to take a little bit longer, but is in our queue. So there is one of the handouts for today's meeting, number 4. I just dropped the link in the chat, and that summarizes all of the questions and requests that came up in July, and then how we are addressing them, or in which of the additional documents you can find the answer. So just wanted to be really responsive to the requests that came up and point you to where you can find more information. Any questions about any of those? Okay, then let's go to the next slide, please. So our 2022 data submission, this is the second time that we've collected data for the cost growth target from the payers, was due on Friday, September 2nd. So we have a hot off the press update for you this week. We were expecting data submissions from 19 parent entities that represent a number of different payers and different payer organizations under that. Of those 19 parent entities, 11 reported on Friday, on time, on schedule. We had granted extensions to the remaining 8 for a variety of reasons. That's part of the data submission process. Of those 11 that already submitted, 5 have already passed the first level of our data validation check. So we have 3 stages of validation to make sure that we're reviewing the data with the payers, that it all looks good, it's what we expected. We don't see any major discrepancies with data last year, whole process built out. So we already have a number of payers moving through that stage 1 validation, which is great. We were really hoping that we had spent time last year building this, really providing a lot of technical assistance and opportunities for the payers to ask questions, improving the data submission template to make that a little easier. And the very initial reactions based on what came in last week look good. So excited to continue to work with the payers as we move through this next round of validation. And this will be the data that will underpin our next public report looking at cost growth between calendar year 2020 and 2021. Okay, and next slide, please. On the provider organization side, We had originally identified about 50 provider organizations that looked like they were going to meet the inclusion criteria for the cost growth target program. That is, they have a connection to primary care and they meet our number of attributed lives threshold. Over the summer, our team has met with 41 of those 52 organizations, and we have one more meeting scheduled next week, and that'll be our 42nd organization. So we are really pleased to have spent so much time talking to providers, introducing them to the program. Some of you may remember that we had originally paused on our provider outreach and education plans because of COVID. We didn't want to go around sort of and doing the cost growth target roadshow. So these meetings with providers were both an opportunity to provide an orientation to the program and review that initial data with them and do some validation. So really happy to have continued those conversations. Those 42 provider organizations that we will have met with by the end of next week represent 95% of the attributed lives in the data. So we have definitely covered the majority of the attributed lives and the costs and are feeling pretty good about those connections that have been made. Of the 10 remaining organizations that we have not met with, we have reached out, we have sent data and information about the program with them. If we hear back from them, if they express interest in connecting with us, we will meet with them, but so far they're all part of that sort of remaining 5% of attributed lives and are not a huge gap in the data if we don't end up meeting with them, but we have shared information and made an attempt to reach out. Any questions or comments about our payer or provider data and validation? Okay, you're making it really easy for me on these updates. Thank you. Oh, Peter.
Sarah, I'm trying to learn how to use the hand gesture item here. You know, in preparing the data submission, I noted from a measurement standpoint that reinsurance was not recognized as a reduction in cost, and it's just something we should think about in the measurement approach, especially as we head in to some of the issues around cell and gene therapy and reinsurance pools. And I'm not quite sure where I'd come down on it in regard to it is a real cost within the system and it becomes a financing vehicle, the reinsurance, but it does have an impact on individual data submissions and the way that that those are viewed, because you may have some really high cost claims that really skew data for a particular year. So we want to think about the usefulness of the data and where do we think about pooling reinsurance, and do we even maybe create a pool of reinsurance that is phantom on its own, but sort of helps us understand what the core drivers are within the cost system and pulls out some of those really large cases that may skew data away from groups that are doing really great work.
Thanks,
Just something
Peter.
to think about for the future.
Yeah, I think I'd love to kick that question to our monthly technical advisory group to work through with the payers. Stefan.
I just wanted to double check. So I read through the document and it said that those 51 providers account for about 60% of all healthcare spending. Is that correct? So in other words, like 40% of healthcare spending is excluded from this.
It's in those 52 provider organizations, we have of all of the member months represented in all of the data across the state, we've attributed 60% of the lives to a provider. We're capturing the spending for the remaining of them just at a different level, not as part of the provider level spending. Not all patients could be attributed to a provider organization. And I don't know off the top of my head of those patients that can be attributed what % of the total spending they are. We can find that out, but I don't know off the top of my head.
Yeah, so I meant like number of patients. I just wanted to.
Yeah, 60% of all of the Oregon covered lives are attributed and represented in those 52 provider organizations. Okay, let's move on to the last update that I have for you on program stuff. Next slide, please. Okay, so this is a little wonky and I'm sharing this mostly as a heads up. I don't think we want to get too into the weeds today, but we have some clarifications that we want to make that we realized were not in writing anywhere, either in the recommendations from the implementation committee or in any of our program documentation for how we were going to be managing provider organization cost growth target measurement and reporting going forward. So there is a document. This is handout number 12. I just added the link in the chat, and it spells out a couple of the problems that we saw and our proposal for how we're addressing them. So this is mostly operational. There are some potential impacts in terms of who meets an inclusion criteria in any given year, but mostly we're just sharing this for transparency and to give people the opportunity to comment if they have comments. So let me give you an example of one of the types of issues that's in here. So the implementation committee recommended a threshold for how many attributed member months a provider organization should have before they're included in the program. That's 60,000 member months in a given line of business. When we're looking at the actual data, some provider organizations that are right close to that 60,000 member month threshold might not have 60,000 member months in both years of the measurement period, because we're looking at cost growth between 2 years. So we said, do they have to have 60,000 member months in 1 year, both years? Does it matter which year? So we wanted to just be really clear about what our inclusion criteria were, how we were interpreting that, and how that would translate to public reporting. So again, this handout just summarizes our proposal, and we wanted to share it all with you for transparency's sake. Please let us know if you have comments or questions about anything in here, but I don't think we were going to dig into anything deeper in the meeting itself. Okay. Well, Lisa, I think kicking it back to you, or anything else that you'd like to hear from us on program updates, or are we ready to move on?
There's nothing that I'd like to hear, but I do want to open it up. Are there questions from the committee on program updates or any additional items on program updates that people need clarification or to hear? Okay, the one thing I will say on the program updates is I feel like the staff do a very good job of updating the website as well. And there is a lot of details on there from our meeting packets that get posted. So if there is something, you know, for me personally, if I hear something once and then I read it and I leave here and I have questions, you can always go back to that. And then those reports. And then oftentimes within the reports that we get are links to additional reports that are on the website or additional citations. And so I really encourage people, if they have those questions or concerns, also to take a look and do that deeper clicking, because oftentimes the answers are embedded in those. I also just want to do a quick shout out to the staff. I think that the data submission work that you all are actually getting done, and that people are submitting their data to both the staff and the industry for taking the program seriously, and doing the follow-up that you all had committed to do when this was established. I think there's lots of questions about, are people going to give their data? What happens if they don't give their data? Why would they give their data? And I think that the work that you all are doing to really drive that, and the work of the submitters and the industry to take this as a very serious role and making sure that we're running the program and moving something forward. I just want to congratulate everybody. And I know that there's a lot of people who had to submit data on this call. So good job if you've gotten your data in, and we look forward to seeing your data if you haven't had the chance to do that quite yet. So I think next we're going to transition to the value-based compact work group, and the discussions that we've had, that we sort of started off having at our last meeting. So I just like a quick reminder from our last meeting is that we had a really robust conversation in July with two presenters actually, and other folks who jumped in that talked about the value-based compact that folks were working on signing. And we talked a lot about what were some of the barriers to actually implementing and moving to the next phase of the value-based compact. And we had a really robust conversation, and I want to remind folks as we move forward in this conversation that not all costs are bad costs. And we had some really good examples of that in our last conversation. So primary care costs, for example, pediatric costs are helpful in the long run of saving us bigger costs. I will, I think other costs. So I think that we're really talking about sort of the looking at provider organizations, that we're really not talking about smaller practice, primary care, independent pediatrics examples of some of those things that we call, that we have carved out as what we would say is value add care, value add costs, and the value-based benefits. And OHA has written up some recommendations. And so I think I'm going to hand it back to Sarah to that we're going to continue our conversation, and then we should talk about those recommendations.
Yeah, so I think we want to recap a little bit of the conversation from July to reset the stage, and then we have some discussion questions for the committee today. So Felisa, do you want me to just present through the next couple slides? Okay.
I'm going off, sorry. That would be great, Sarah.
Okay, cool. Next slide, please, Johnny. So just to ground everyone, again, this is our annual cycle model for the cost growth target program, where we're measuring, analyzing, and reporting. But really, that if all we're doing is measuring and reporting, that's just some data. We really want to be using that data to identify strategies and opportunities for cost containment, cost growth mitigation, and implementing those strategies. So all of this is really about driving to the left side of that cycle to taking action. And the cost growth target program, one of the very first strategies that emerged from conversations with the previous implementation committee is the value-based payment compact. Next slide, please. Oh, sorry. Okay, so the implementation committee identified principles for accelerating the adoption of advanced value-based payment. That was seen as a key strategy to meet the cost growth target. That work has spun off to the value-based payment compact that has been signed by a number of organizations across the state. And the work group has been developing next steps, a roadmap for implementing that work. And this is all, again, foundationally, this came from the implementation committee on the cost growth target work. However, there are some questions about how this is all connected. So while the compact supports the achievement of the cost growth target itself is not the emphasis of the compact. The compact goal is increasing the use of value-based payment, which can have the focus on containing costs, but also improving quality and health equity. Next slide. So the value-based payment compact, this is a voluntary commitment from payers and providers across the state to increase the use of value-based payment, especially the advanced value-based payment models. So lowering the rate of cost growth, focusing on improving health equity, improving quality and health outcomes. The compact includes principles that set the target, center health equity, and focus on those advanced models. So I know that we shared the roadmap and the compact document in previous meetings. They're also online. We can share them again if people want to take another look through that, but quick snapshot of what the compact is. Next. Reminder about the value-based payment compact work group. The work group is charged with implementing the compact. That group was convened by OHA and the Oregon Health Leadership Council with support from the Hospital Association and the Oregon Medical Association. The work group is identifying paths to accelerate the adoption of those advanced value-based payment models, highlighting challenges and barriers to implementation, recommending policy changes and solutions, coordinating, and monitoring and reporting on progress. And in July, you'll remember we spent a chunk of the agenda going through those challenges and barriers and strategies in detail. Next slide. So just a quick summary of what those challenges were that we talked about in July. This is what the work group, the value-based payment compact work group had agreed on. It took them 6 months of conversation to come up with this. So there's a lot of detail behind each one of these bullet points, but just to recap, transitioning from fee-for-service models to a value-based payment, especially an advanced value-based payment, that requires deep operational and cultural change for payers and providers. Having multiple value-based payment models is challenging, especially when staff have to spend time tracking and reporting on different things or different payment systems for different models. There is provider concern about significant financial losses or potential financial losses, especially as they move into more downside risk arrangements. There is a need for a robust data infrastructure for providers to be able to be in these arrangements, provide the reporting that's needed for these arrangements, as well as manage populations to help meet any requirements of the models. Risk adjustment is really key as part of all of this work, but the existing risk adjustment models do not necessarily account for medical and social complexity to the extent that we want them to. So there's some interest in improving those. There's interest in incorporating social risk adjustment models, but there's not a sort of one size fits all model for this. So there's sort of a lack of meaningful models in this space. There's also lots of different models for attribution. So again, that concern about lack of alignment and how patients are being attributed to providers, which patients providers are accountable for. Providers might not know which patients they're accountable for. Lots of complication with attribution models. There's also a large number of payers and a large number of medium and small clinics in Oregon. So there's just sort of a size and complexity of scope. There are a lot of different arrangements and different contracts that would need to be negotiated and talked through. So just sort of a volume issue here. Also, some practices have really small patient populations, and that factors into how they would be able to participate in these models or the investments needed to participate in these models for those small number of patients. And then, of course, COVID. As COVID continues, that has really had impacts on the health system, including workforce burnout and staff shortages, and all of that factors into challenges for value-based payment adoption. So I went through all of that really fast. I'm not the expert. We do have folks on the call who can speak more coherently to any of these challenges. But I think we want to open this up to the committee here. So do these challenges resonate? Is there anything missing in these challenges? Are there any thoughts about how these challenges relate to the cost growth target work? Any reflections that you'd want to share at this time? Melissa.
I see Melissa's hand.
Yeah, hi. I think a couple things, in particular on that last bullet point on the COVID-19 repercussions. The world has shifted so much since COVID, and I just wonder if the benchmarks need to be looked at again that were set prior to the pandemic and what's achievable now. And so that would be a question. There's so many new considerations we have to look at, and you outlined a lot of them here with capacity and workforce. And I think the challenge is as this moves forward is what happens for patients that aren't a part of a value-based compact or aren't part of or part of non-contracted services. How does that shift or change when there's limited access, which is what we're seeing right now a lot in the marketplace. So just a couple things. I don't think we can kind of underestimate where access and the challenges for capacity are and how much that has changed, and maybe that we need to reconsider timeline or benchmarks. Maybe those need to be reconsidered or looked at.
Okay, I see a hand from Lawrence.
Hi, thank you. I think this is a really good list, and my comment is probably could fit under lack of meaningful risk adjustment, but I'm kind of coming from a career in quaternary care academic centers, and that's that, there's a very small number of patients who, often out of the blue, I'm thinking of a family member of my own, who get really, really serious diseases. That wake up with head and neck cancer or a dissection of the carotid artery causing a major stroke, and how that's captured within this, given the large number of dollars that are often related to a small number of cases that are kind of struck by lightning, bad things that fortunately we can do more and more about as we go forward in time, but unfortunately cost more and more money.
Yeah, I think that actually is part of the value-based benefit design. So I'm actually going to kick it back to staff to sort of answer that question about, I think that is how the design. So Sarah, should I kick that to you or Chris?
Why don't I go to the next slide and just recap the strategies, and then we can go back to the open discussion. I think that might help tie some of this together.
Great. So Stefan, if you can just hold your question and then we'll come back to you.
Okay, So again, this is a recap of what was shared in July. This is also in much more detail on page 13 of the roadmap that we shared before. So the value-based payment compact work group has spent months working on strategies and coming up with strategies that will address those challenges and barriers. So just to summarize what those strategies are, the first is development of a short menu of value-based payment models for use in Oregon. This would really address some of the model alignment issues. The focus would be on models for primary care, for hospitals, and for specialty care. Second strategy is developing a compendium of value-based payment tools. These would be tools that would focus on both payer and provider engagement with VBP. So that would have some foundational work like quality metrics, data capacity, workforce. It would also be tied to implementing some of those new models from that short menu. The third is strategies to integrate equity considerations into all of value-based payment efforts. Again, focusing on the short menu of value-based payment models and the role of equity in those models. Fourth is addressing provider concerns about risk and financial loss. So the toolkit will include some information about that, including things like establishing risk corridors. The fifth strategy is policy alignment. So maximizing the program and policy alignment where possible. That includes things like engaging with the Health Information Technology Oversight Council to monitor and support the development of data and health information exchange infrastructure in ways that would also support value-based payment work. And then finally, looking at attribution. So addressing the barriers and coordinating some of the work between the value-based payment compact work group and the primary care payment reform collaborative. Lots of work groups happening here. So again, trying to connect and align the efforts across the different bodies that are working on some of these topics. I think, and I might defer to Chris and Diana, that some of what Lawrence was saying about the small patients or the small number of patients that could be high cost outliers, some of that's captured in attribution, thinking about the small patient payer lineup, as well as in some of the specific models, but I'm not 100% sure about that. Chris or Diana, could I defer to you?
Yeah, hi everybody. I'm Chris DeMars. I'm Director of Delivery System Innovation and help staff the VBP Compact Work Group. We are just getting into the issue of risk adjustment now, those conversations. And so I don't have a concrete response for you, but I will say that this has certainly come up, and not just with regard to clinical risk kind of outliers, but also those with high degree of social risk as well, and looking at perhaps incorporating some sort of social risk adjustment, though the science on that is not incredibly sophisticated at this point. So we're going to be trying to figure out kind of how to knit all of that together. But I think it's a great point, and we'll bring it back to the compact work group for further discussion. So thank you for mentioning that.
Okay, I have a series of hands that I saw come up earlier that I want to go to first and then move, but we'll go to Stefan.
Yeah, thank you. I guess I have two questions. One is, so VBP involves, that's a big name, and so is there any tracking here of different levels? So, for instance, 2C is in the HLAN framework. 2C level is VBP. That involves fee-for-service with meeting quality goals. You get a bonus. So this is like one pretty popular VBP. But it doesn't have any cost savings involved in it. And so I was just wondering whether you track some sort of any restrictions here on what kind of levels people should switch. And the other one is, I was wondering how that is coordinated with value-based payment roadmap for the CCOs.
Chris, did you want to take that?
Sure, I'm happy to. Stefan, can you repeat the second question? I have the first question, but could you repeat that?
Oh, I was just wondering how this links to, so there's the VBP roadmap over Oregon for the CCOs, so for the Medicaid program. There's a specific, the CCOs are tasked with increasing VBP, and so I was just wondering how this is coordinated with that requirement.
Two excellent questions. So with regard to the first, yes, there are many different types of VBP models, and per direction of the Cost Growth Target Implementation Committee that set up the principles and the targets, they kind of landed on advanced value-based payment, which does not include the category 2C or pay for performance that you mentioned. It starts with category 3A, which is shared savings, 3B, which is shared risk, and then category 4, which is population health. So more advanced than the 2C. Do you have any follow-up questions on that before I get to the CCO connection? Okay. And then with regard to CCO, once again, a great question. They, in 2020, the CCOs became, for anyone who doesn't know, are required to meet certain targets similar to the targets that are in the compact, except that the CCO targets do include the category 2C. So not quite as aggressive, and the percentage by year are slightly different. All the CCOs did sign on to the VBP compact. So while their targets are not as aggressive, they have all signed on to voluntarily achieve these slightly higher targets that are laid out in the compact.
Okay, I saw the next hand I saw was Melissa.
Yeah, I mean, it's just speaking again to the attribution model and the critical nature, as you were mentioning, between the two programs. And then with this work, as provider organizations want to understand, that accountability, and they do want to be accountable. If there's not better alignment around that, it's really challenging to actually do the work and be successful. And the toolkit and the data, right, are just critical pieces of that as well. These seem right though, what you have here.
And then I saw Nick's hand go up, so I wanted to give you a chance to jump in here, Nick.
Sure, thank you. And it really, for me, it's going back to the previous slide with challenges, VBP challenges. I think it was probably beyond the scope or outside of the scope of the VBP compact work group, but it is part of cost growth. I worry that the complexities of VBP may unintentionally encourage a lot of small practices to consolidate into larger groups. And I think consolidation has a significant cost growth risks. I wonder about the state of research on that, or other things that the committee should be thinking about in terms of consolidation. We don't want to accidentally encourage lots of consolidation.
Can we put in a plug for our other program, the Healthcare Market Oversight Program, to monitor consolidation in Oregon? Is this a good time for that plug?
It is. So I do think that I want to just say, I think that all of these changes, and as we talk through VBP, I think to both Melissa's point and Stefan's point, they don't work alone. And so we have a whole set. I think we're talking about the sort of the value-based payment compact in this moment, but I do think the CCOs moving in alignment with this is as critical as making sure that this works and that we're on a timeline to make the compact actually real and begin implementing the compact. And then I think to Nick's point is also connected to the market oversight program. So I definitely think we can, how these things work in concert together, I think is a really critical point. And so what might be helpful is then coming back on some of these discussion items where we have a little bit of the overlap and making sure that the board has the information and clarity about where there is overlap in working through some of these programs, so folks can see that. Are there other?
I'm
go
really
ahead,
sorry,
Nick.
but
I can't see your face.
another
Thank you.
Possibility or suggestion may just be that in addition to a menu of VBP models, for example, maybe there's value in developing a menu of sort of consolidation or networking options, that we could help practices to consider. And I'm speaking to this as a somebody who helps run a small clinic. We know our options for consolidation. It's harder to figure out our options for maybe networking arrangements that help us negotiate a contract with partners and payers. And so I think some practices would value hearing that those things exist.
Great.
Lisa, can I bring everyone? Sorry.
Oh, no, go ahead, Sarah.
I was gonna see if, I think you were starting to tee up one of the questions that we wanted to ask the group today. Really thinking about how do we keep this work connected between the value-based payment compact work group and the cost growth target committee. And we want to make sure that the cost growth target committee is, aware of this work happening, but also this is currently one of the primary strategies for cost containment and cost growth mitigation. And so this is something that we should care about quite a bit, and wanting to make sure that we're supporting it in a way. And so I know that in July, our conversation, we ran out of time for a conversation. And I think we wanted to make some space for that today about how do we keep this work connected? What kind of frequency, what kind of updates, what kind of information, how would it be helpful to continue to bridge this so that cost growth, cost conversations are being connected with value-based payment compact work and vice versa. So I don't know if we have a specific proposal for you and how we do that, but I think we just wanted to make some more space for that discussion. Felisa, would you tee up any other specific questions?
No, I do. I think that is, yes, I was trying to do that. So thanks, Sarah. The other piece, I think that the other question that I would ask this group, and I think there's a lot of expertise in here to Nick's point, is there a place where we can we should be bringing back either examples from Oregon of success stories and how this has worked and to transition to mitigate these issues, or from other places? So not everybody jump in here. So I guess, and I can't see nodding heads. So if there's nodding heads, please somebody just tell me there's nodding heads. But I think the first question is, how often should we bring back this discussion? Is that a 6-month question? Is that an annual question? Is it quarterly? This is one of our core strategies.
I think
okay.
My opinion is it's probably at least 6 months, that would be my opinion, but I think annual is probably not enough, at least if there's movement in the discussion and really connecting to this work.
Great, that's helpful. Stefan?
Yeah, thank you. I think half a year seems reasonable to me as well. I just want to mention to you, say it's a core strategy. There's not a lot of evidence that VBPs reduce costs, at least the ones that have been studied so far. But it doesn't mean that this can't work or can't be effective, but it's some sort of something to keep in mind as you monitor that.
Great. So can I ask a question back to you on that, Stefan? So the research and studies that you've seen so far, and we do think it sort of has been the core strategy that kind of was put out. So if you were to say, when's the date, like if we were to look at this over a time length period, when would be the date that we'd want to have a more deeper analysis about whether it's moving the dial on cost?
So I think there's, putting me on a spot here. I think I guess I have two things I'm thinking about. The first one, I think it would be useful to know how many patients are included in these VBPs and at what level. So kind of roll out. So it's a voluntary program. You see, which have signed up. That can mean a lot, right? It can mean like 80% of people are enrolled. It can mean 20% of people are enrolled. And then also as I said before, it's like VBP can mean different things. So it's like you say like it's free and higher. That is still like on fee-for-service architecture with some post adjustments and post quality settings. So it might also be good to see what that, at what levels these are. And so I feel like, depending on the timing of this, perhaps half a year would be helpful for that. I'm not quite sure, maybe a little earlier even. The second question, I guess, from my perspective is, it's a queue, I want to be careful to be like, to not extrapolate too much, right? So there's research that looked at some of these initiatives and found relatively little cost savings. But here, it's like a little bit different, right? In the sense that you have, you can think about this as a tool or a mechanism for which you can receive cost saving. So the fact that like some previous studies haven't found strong cost saving findings doesn't mean that it's not the right tool. It can be used for that. But I think it would like, it would some sort of like be a different way to use it than it has been in some of these other contexts.
Okay. I think that to me that was just a very helpful piece. So there's a couple of things that I think are important in this discussion that I'm kind of seeing coming through here. Is one is I think there is, oh good, Zachary put the links to the data on about the number of lives that are covered in the chat. So and where we're at on and in what level each of we're at on VBPs, which I think is telling. And then I think this idea of the 6-month check-in, and then this question of the cost savings. So if I were to kind of frame these out a little bit, I feel like what I think might be most helpful is we have the compact. So where are we at on meeting the goals of the compact? We should check in on it every 6 months. And then I think as the time frame goes on, if we're checking in on that every 6 months, we should probably have a longer, at least annual conversation of, is the compact that we're moving towards actually getting us some of the outcomes that we're looking for, and that actually might be a multi-year question to make that determination. Is that fair? Is that sort of a fair assessment? And then I'm gonna, Ivy?
Yes, Ivy here. Is it Stefan? Stefan, I had a question. So on BBP, you had mentioned that research doesn't bear out that there's cost savings. I just wondered maybe next time we speak, if you could speak to where that, what that research is going from, where that comes from, because that's not really, I think in other states, what I've heard to be true. I'm just wondering where that's coming from. But, of course, there's, different sources. I didn't know if you could speak to that, one. And then two, I think the outcomes around health status overall are very high for value-based payments, which is not what we're unfortunately looking at here. That's not, our job, right? So, but I did want to know if you could speak to that more. And obviously they go hand in glove, and that's sort of a drawback for this committee, is that that's not really what we're looking at. So I was just kind of surprised by that, because I think we'd all heard that really value-based payments drove cost, and apparently that's not the case. So I just wanted to hear more on that, or drove costs down.
Should I respond?
Yeah, Stefan, I don't want to put you out. I don't want to be like, Stefan, please
no,
explain the entire research that you've done on value-based payments.
I enjoy this.
Sorry.
No, this is a great question. So I think like it would, if you have some literature you want to share, like I base mine on a couple of articles that were published around, let me see, Medicare, like the Medicare Pioneer Program and the Medicare Shared Savings Program, the Joint Replacement Program, that one was also evaluated. It was a randomized control trial. Those are 4, and then I think I have another one. Those are the articles I know on top of my head. But
awesome.
it's like that's like one little thing. So if you know articles that show different results, it would be really helpful to see. Just to clarify, these articles do show cost savings. They're just not like in extensive fashion, or some of them show, just not in extensive fashion. So it's like it's a bit of a mixed bag there, but like I'd really welcome any other evidence you have. I think it would be really interesting to see.
I think honestly, it's more on the payer side, and you guys can cut me off, but it's more on the for-profit payer side. It's rather extensive, but it's probably the implementation. I mean, that's always what it gets down to, right?
Yeah, it's like it's not a given. Like as I said, it's like VBP is so big, and there's so many ways to implement it that you can have 2 different VBP programs, and they can achieve very, 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 very different things. So it really depends on the implementation.
This is a helpful discussion, I think, on the sort of question about the value of VBP. But I think I see Chris, who probably wants to jump in on this topic. So I'm going to go to Chris next, and then I'll come back to you, Peter, if that's okay.
Thanks, Felisa. We have a kind of meta synthesis of the data on both cost and quality outcomes by different VBP models that I can send with Sarah to share with you all. And it does show that the more advanced VBP models do have a better kind of outcome with regard to costs and quality. So I will make sure to get that to you. But you are right, Stefan. In some cases, depending on the model, the data do not show the outcome we want to see, but in many other cases they do. So I'll share that with you, and we could talk about it at the next time we all come together.
I also just want to jump in here really quick, because I do think that I think that for the tracking of this, and to Ivy's point around the payer here, is I do feel like the VBP model on the payer side is a little bit of a different question. And then I also think the other piece of this is we shouldn't expect a reduction in our overall cost. So it's a sustainable cost growth. And so we'll still see cost growth. And so could VBP help us slow the rate of growth? So I think I misspoke earlier when I was talking about cost savings. So I just want to jump in there on that. So Peter.
Yeah, you bet. I really appreciate this discussion. I think it's really important for the committee as we think about what's really going to contain the cost trends that we're fighting. One of the things that I worry about, and I'm a big fan of value-based payment, and I think it's a really critical component. It can't be the foundational component of what we're doing, because it focuses, I don't know if foundational is the right word or not, but it can't be the only piece, obviously. It focuses on our local provider system to control costs in a system that's being driven, as Lawrence pointed out, by innovation in treatment, inflation on pharmaceuticals that we cannot control, the development of new drugs, the approvals of various procedures and drugs on a national basis. And so as we as a committee think about this work, I think it's really important that we not try to leverage everything on our local provider system as to figure out how to be the counterbalance to all these things we can't control. I think there's a real risk there. And I think value-based payment, while it has a very significant place at the table, can be one of those pieces that it's easy to say, hey, let's pass the risk on to our provider system or our payer system, either way, and that'll solve the problem. And I think it only addresses a piece of that utilization question that we have to confront.
Thank you for jumping in, Peter. Here, I agree, and I think that I do want to talk about this as one, make sure that we are sort of on track. This is one component of the many things we're about to do on work. And we're about to have another half of this meeting that is all about pharmacy, which is our other favorite topic. So I do think that Chris has some, I think that we do have some of the things that Chris outlined around the work that the work group is doing on this topic itself. And I want to make sure that I saw in the chat that Angela sort of thought that my timeline that I kind of outlined was the right timeline. I do want to leave that. I want to give some space to open it up and say, is there an additional timeline for follow-up on this that people would suggest?
Lisa, I want to add one thing, which is to your point about monitoring the reduction in growth and how much of that might be due to VBP. I don't know that we'll ever truly be able to say that causally, but in the cost growth target data submissions that we're collecting, we are breaking out the dollars into claims and non-claims based payments and looking at specific types of payments. And so we should be able to trend that and see how that's changing as part of our data submission and reporting. So in addition to the payment arrangement file data that Zachary linked to in that dashboard, we'll have some specific data from the cost growth target program that we can also look at probably annually coming out of the data submission that will help answer that question.
Great. And I think the only other, my hand is not in the queue, but I do want to mention here, I think that, you know, Chris had talked about the risk adjustments and the social risk adjustments. I want to make sure that we are being very, very cautious on doing social risk adjustments, because oftentimes when those social risk adjustments have been made in other areas, including healthcare, they've turned out to be real racist, like super racist. So if we could just make sure that what we're focused on and leading with extreme caution in that area, I'd really appreciate that.
If I could,
and I can't see anybody.
I'm sorry, my connection is slow, but we completely agree, and that's why I made the comment about there's not a proven way to do this well, and so, but we are pursuing what could be done so as not to adversely harm a practice, for example, or members that have complex needs.
Okay, great. Thank you, Chris, for jumping in there. And then I think the only other, you know, I just wanted to hear if there's any other payers in the room who want to jump in on the VBP conversation or have anything to add. I want to leave some space for that.
Yeah, this is Hardash, and you know, the couple things I would add is I think we've got to just keep the objectives in mind, right? On value-based contracting, you know, when Medicare did this, you know, a lot of people have done this. There has been some success in doing this. You know, DRG is sort of a BR, you know, a value-based system, right? It's a payment based on case versus per day. So, but I think that you know, if you look at the two things that with the payer side we look for is a value-based, you know, it's volume-based or value-based. So volume-based, you know, the thing here is unwarranted or inappropriate utilization just to increase revenue, right? So that's from the payer side. We just want to make sure that, I think from the payer side, be like, what is that unwarranted variation in utilization that may be inappropriate? And the second thing is really productivity. You know, you force productivity if your payment income or a payment is prepaid. So, you know, if you keep those objectives in mind, and I think it's not always a solution, it's one of the tools you have in the toolbox is the value-based. It is not the only tool, but I think from the payer side, I see a lot of times that the value comes in utilization and again, productivity. Yeah, go ahead, Regents.
Yeah, Angela.
Yeah, I was going to add, I don't disagree with Hardesh's comments there, but this is more of an observation than anything else. Is what's happening right now when we're having value-based conversations with providers is the need to focus on the here and now from a provider perspective and the financial challenges that are occurring and the labor challenges, that the value-based discussions are getting sort of sidelined for a period of time. And it's for good reason. I'm not disagreeing in saying that the concerns that providers are having today are not warranted. It's just, it's the value-based work is kind of being put on the side for a little bit. And so when you stated, Felisa, that every 6 months or so we can come back to this, it takes a long time to get these programs put in place. And so a conversation that started, you know, 6 months ago, 9 months ago, that conversation takes time to take place. It takes time to come back and measure it. And so at this point in time, that's why I agreed with your comments and cadence, but eventually I think we need to tie the two a little bit more closely together. But what's happening in the environment today just creates that cadence and that timing maybe a little bit further apart than we would all like and feel good about.
I think Julie, is there anything that you'd like to add? I know that you operate, Intel has many of these arrangements.
Sorry, we get off mute there. No, I don't have anything additional that hasn't already been provided.
Okay. Okay, so I think my sort of takeaway, and I'm going to restate, and I think that if we and I think to Angela's point, like I do think that change is going to be hard, right? And it's hard generally. It took us, I think, 14 years, and Jeremy actually may say longer, to get to sort of the compact phase. It will take us a long time to implement. So we're going to do a regular sort of 6-month check-in on this and sort of a more annual deeper dive so that we are moving and driving the conversation. And then I think we'll get to and to Sarah's point, that will be part of the measurement phases that we're looking forward through. So if there is, I see the links for the additional materials here, learning materials. And I think that we are at our break time. Am I lying about that, Sarah?
We are at break time.
Okay, so we're gonna take a 10-minute break, and then we're gonna come back and, like I said, talk about our other favorite and most awesome topic, pharmaceutical costs. So just a 10-minute break and I'll pull us back together.
It is 3:20. Let's go ahead and reconvene. Okay, next slide, please, Gerandi. Okay, so we are going to jump into pharmacy costs and spend the rest of our time today on this topic. So I have a couple of introductory comments, slides to just set the stage a little bit, and then we're going to get into the weeds. So I think first we want to acknowledge that thinking about pharmacy costs, thinking about potential strategies to address pharmacy costs, this is a multi-year, long-term conversation. This is probably something we will be talking about for a while as a committee. We're not going to be done with this topic today, so I think I would encourage you to think about today as some background information, some grounding, an opportunity to identify places where we might need to ask more questions, might need to request more data, where we want to go to have informed conversations about potential strategies around pharmacy costs. So apologies that this is going to be a little presentation heavy. Joined by some colleagues to co-present some of this information, but we really wanted to just ground everybody before we dig into discussion of potential strategies and where we might want to go with Oregon's work. Okay, next slide. So just wanted to remind everyone that when we looked at the cost trends report last meeting in July, pharmacy costs were the main driver of cost growth between 2013 and 2019 in all three markets, Medicaid, Medicare, and commercial. Disclaimer, of course, next slide. This data does not include rebates. This is claims only. So claims only before any rebates were applied. We know rebates have a big impact on pharmacy costs. For example, in one Medicaid case study, found that Medicaid gets almost 55% of the cost back in rebates. So we are going to continue providing some more information and data in future meetings about the impact of rebates on pharmacy costs and looking at pharmacy costs with and without rebates as part of cost growth reporting. But for the analysis that we presented, we did not take that into account. That said, pharmacy costs were a large driver. We know they're a large driver, and we want to spend some time talking about that. Okay, next slide. In general, spending on prescription drugs is going up nationally. This is some national data that the Peterson Foundation put together. We spend 3 times more on prescription drugs than we did 20 years ago, and spending is projected to continue to increase by 63% over the next 10 years. Next slide. And there are a lot of factors that are driving this growth.
Sarah,
yeah,
jump back to that last slide for me, if you'd be so kind.
Sure. Do you want to go back one?
Do we have a comparable slide of how we compare with our spending versus other developed countries?
Ooh, I don't have a prepared slide in this deck, but I know that exists, and we can push that out. I know what you're talking about.
Right. I think that might give us a benchmark of what's possible.
Yep, definitely. And folks on my team, if you know exactly what Peter's referencing and want to drop that in the chat, please do so. Otherwise, we'll send a follow-up email. Okay, let's go back to the next slide. So there are lots, well, back one more, sorry. There are lots of reasons, and again, pharmacy is a very complicated topic. There's a lot of different angles and lenses on this conversation. There are a lot of different potential levers and opportunities, but in general, sort of the common consensus around what's driving pharmacy cost growth includes the high and rising prices for brand name drugs, the lack of competition for the way that pharmacy works in this country, the cost and use of specialty drugs, and a lack of transparency in drug prices. So very high level, next slide. So for today's conversation, we are going to do a couple things. We're going to share a little bit more data on pharmacy spending in Oregon specifically. We've got some information from the Prescription Drug Transparency Program, and we also have a pharmacy spending by drug category analysis that breaks apart what we shared in July one level of granularity deeper. We're going to give you a very high-level overview of potential federal and state policies that exist or that have been proposed as sort of a master menu of ways to address pharmacy costs. This is to just sort of lay everything out and give you the spectrum of options that we could choose to talk about. And then we're going to take a closer look at two programs, two strategies that are already in place and moving forward in Oregon. And Ralph Megrish from the Prescription Drug Affordability Board is going to present on those two at the end. So we've got a couple of pharmacy subject matter experts on the call that we might also tap for specific questions as they come up, but that is the plan for this agenda item. Any questions about the plan for the next hour before we dive in? Okay, let's go to the next slide. And one more. Okay, so starting with the Prescription Drug Price Transparency Program. So Oregon has a Prescription Drug Price Transparency Program. Ralph is going to speak to this in a lot more detail later on, but we just wanted to highlight that this is a source of data that we can look at in understanding what's happening in Oregon. So in the annual report that this program puts out, they collect information and report on information both from prescription drug manufacturers and from insurance companies. So they include data on new high-cost drugs, annual price increases, and upcoming price increases. They also report on the top 25 drugs and the impact that those drugs, that the drug costs have on premiums. And Ralph, I probably just butchered that, so I'll leave you to correct anything that I said incorrectly. There is a link to this report. There's a lot of really great data in there. We're not going to go too deep into this today, but just letting everyone know that this is a resource, this is a program, and as we continue to talk about pharmacy costs and what's driving pharmacy costs, this is a fantastic resource. Next slide. And just a snapshot from that report on the annual price increases. So manufacturers are required to annually submit a price increase report on any of the drugs that has a list price of $100 or more for a 30-day supply. Anything that's going to increase more than 10% from the previous year. In the 2021 report, the Prescription Drug Price Transparency Program is reporting that 71 drugs reported a price increase. The median reported price increase was 27% for generics and 13% for brand drugs. And the most common class of drugs was a type of antibiotic. There's a lot more detail in terms of different classes. Next slide. This is just a quick snapshot of the most costly drugs from that annual report. And there was one more thing I was going to say about this. This is the most costly in terms of the 25 generic, the 25 brand name, the 25 specialty drugs that have the total highest payment. In the 2021 report, more money was reported spent on anti-inflammatory drugs than on any other drug classes. And most of that was for Humira, a drug for arthritis and a number of other conditions. That has been the highest, most costly drug that Oregon's reported on in the last 3 years of this program. So again, very high level. There's a lot of information in this report and Ralph will tell you more about it. Ralph, anything you want to correct immediately before we keep going?
Not at all. Just would note that we're only about 3 months away from releasing our 2022 report. So really looking forward to having a refresh of new current information.
One other thing that I would add that the prescription drug price transparency program does is really focus on the impact to consumers. So they collect consumer testimony, consumer stories, and a lot of that is included in the report. And it's really powerful and really, again, tying this, which we talk about this in the millions and billions of dollars, but really understanding what this means for people in Oregon. So, okay, we'll come back to the prescription drug price transparency program, but let's talk about some subcategory analysis. Next slide, please. And one more. So in our report that we presented and talked about in July, this is a claims-based analysis looking at cost growth by service category between 2013 and 2019 in Oregon specifically. Pharmacy was one of the service categories that experienced the most growth in that time period. Next slide. And if we look at that both by market and sort of over time and per person, you can see that between 2013 and 2019, pharmacy costs increased, the pharmacy service category, so spending on pharmacy increased 184% in those 6 years for Medicare, 93% for commercial, and almost 80% for Medicaid. The lines themselves are the actual per person dollar amounts per year. So Medicare has higher per person costs in pharmacy than the other two lines of business, which is probably what you'd expect. So again, this is what we looked at in July. This is just setting the stage before we start unpacking what's actually in that pharmacy service category. Next slide. So a little bit on the methodology of what we did. We looked at the all-payer claims database again. We looked at release 9. Previously, we were reporting release 7. The APAC data have been refreshed. So now we're looking at release 9, but we're still looking at that 2013 to 2019 window. It's a pre-COVID window. The claims data are very complete for that period. We then used the AHFS classification, which is ways to classify drugs, and looked at how all of the pharmacy service category spending could be stratified into these various subcategories. So a couple notes here is that one drug could be reported in multiple subcategories, so it's not necessarily a mutually exclusive classification. There are some drugs that are not in any of these categories, so we have a very large sort of other bucket once we get to the subcategory analysis. And don't try to add up any of the data that we're going to show on the next couple of slides, because drugs can be in multiple categories. You can't sum all of these categories. It will add up to more than the total that we just shared on the previous slide. So sorry, that was wonky. Any questions about that before we dig into the findings? Okay, great. Next. And of course, this is all, again, claims analysis. None of it incorporates pharmacy rebates, which may show up at the payer level, the PBM, the provider, the patient level. So no rebates accommodated for at all. Okay, next slide. So those subcategories, we can break up pharmacy spending into 25 different pharmacy subcategories. Again, that's the AHFS classifications, and this is what those categories are, just at a very high level. Next slide. Then we looked at which of those 25 subcategories had per person spending above $30 in 2013. That brings it down to a shorter list of those 25. And note here that the AHFS classification has a miscellaneous category that is essentially other. And then we have also our other category that we created from everything that didn't roll up. So there's sort of two others in this bucket, but they all have per capita spending above $30 in 2013. So then using that as the base, sorry, next slide. Let's actually look at what the per capita spending is for each of those categories above $30 per person. So in 2013, you can see the range here, $34 per person for anti-infectives, $30 for ear, eye, nose, and throat drugs, $88 for hormones, $139, almost $140 per person for central nervous system drugs. And I should probably say we are here just looking at total spending. This does not disaggregate into price versus utilization. So there's no sense of, is this one person who has one very expensive drug, or is this lots of people who have inexpensive drugs? That's not a layer that we've added. We're just looking at the total spending in each subcategory for now. Questions about what we're showing so far? Okay. So then let's keep looking at those categories and we jump to 2019 on the next slide. So between 2013 and 2019, we add 2 more categories where the per person spending was above $30. So now we're looking at drugs for blood formation and coagulation, as well as skin, so various dermatology treatments. Next slide. So again, looking at the per person dollars, the total spending for each of these subcategories. Now in 2019, you can see that we've experienced an increase in a number of these categories. Some of them more than others. And actually, this is a little bit more clear on the next slide. So let's go to the next slide to talk about that. So for those categories where per person spending is above $30, you can see what the data were. Left column is 2013, middle column is 2019, and then the growth itself is in orange on the right. So there is an increase in every category that we're looking at here, but that increase varies. We have 300% growth for anti-infectives, almost 300% for anti-neoplastics, only 40% for central nervous system, but that started at a higher dollar amount. So really, this is the takeaway. There is a lot of variation. I think this was the question that came up in July, is like, what drugs are driving this? And the answer is, it really depends. There's a lot in here, and there's a lot of different drugs in each of these categories. We can keep going. We can keep drilling this down. I think the next biggest question is price versus utilization. How many people are on each of these drugs, and are some of them just very expensive? But looking on a per capita basis, which allows us to compare across all of these subcategories, this is what we see happening between 2013 and 2019. Any questions about this comparison? Any comments about this comparison? Those of you who are more clinicians or practicing, does this align with maybe what you've experienced in the field? Okay, pretty quiet. Let me go through a few more data points here. Next slide. So we then wanted to know, we know that pharmacy as a category was growing, but which of these subcategories contributed the most to that growth? So again, still just looking at total spending, not by price or utilization. We are also not looking at when new drugs entered the market. So over this 6-year period, new drugs entered in these various categories, and that could lead to an increase. And we're not able to take that into account at this point. So again, this is a very rough way to look at this, but generally, which of these categories was contributing the most to the overall growth? So remember those bubble charts that we looked at in July? Let's go to the next slide. On the reading the graphs from left to right, if the bubble is further to the right of the chart, that means that it had higher cumulative growth in that 6-year period. If the bubble is higher from top to bottom, it means it's more expensive per person, has a higher dollar amount per person. And then the larger the bubble is, the more that category is responsible for overall pharmacy growth. So hopefully you all remember this from July. This all still makes sense. Let's look at which of the subcategories was most responsible for growth in each of our 3 markets, Medicaid, Medicare, and commercial. So next slide, starting statewide, we have miscellaneous therapeutic agents. That's one of our catch-all categories. That is one of the largest contributors to statewide growth. It's not very helpful because that's a miscellaneous category. We also see hormones, pretty large contributor to growth. And then we had the very large cumulative growth for those blood formation, coagulation, and thrombosis drugs that I mentioned earlier. So that's the statewide picture. We go to the next slide and look at commercial. We start seeing a little bit more nuance. So hormones, a little bit lower here, but still miscellaneous therapeutic agents, hormones, and blood formation coagulation drugs experiencing high cumulative growth. Pretty similar to statewide, not too much difference. Next slide. If we look at Medicare, it's a little bit of a different story. All of the dollar amounts are a little higher. Medicare per person spending is more expensive, more total spending is more expensive. Hormones are the larger contributor here. That is a growing category. That category contributed a lot. We also see antianoplastics as a large contributing category to the total spending for the Medicare population. And the blood formation bubble is larger here than it was on the other slide. So a little bit more of a contributor in the Medicare market. And then finally, last slide, looking at Medicaid. So here you can see things are a little bit more clustered on the left. They're also cheaper. The axis is different. So Medicaid per person spending is a lot less. And also we're seeing less cumulative growth, more or less, but a couple different drugs are contributing here. So we see the anti-infectives as a category, as well as the central nervous system drugs popping out as some of the larger contributors. The y-axis is per capita spending. Yes. I went through that very quickly. Let me stop. Reactions. Do you want me to go back? Do you want to see any of these side by side? Does this all make sense?
Sarah, I think this is pretty consistent with what we're seeing in the actual market. I do think it's really interesting that because of some of the really high cost percentage increases and dollar increases, it's hard to remember that if you think about a 7-year period of 3.4% inflation, I don't know, that's around 20-some percent, 25% or so increases. So almost none of the drugs fall within that. So those that are clustered around closer to the left-hand axis feel like they're not as important, but they're 100% plus and just dwarf some of the goals that we have. So I do think it's important not to get overwhelmed by some of the large increases in certain categories, and remember that all these categories are well above what we've set out as our targets.
Yeah, thanks for that point, Peter. Jeremy, can you go back to the slide that had the bar chart comparison? I think let's look at go back a couple more. Back. There. Yeah, I think that cumulative growth, what you're saying, if we looked at 3.4% growth every year cumulatively compared to what we actually saw, every category here is going to exceed that. And I think you're right. It's really tempting to say, oh, very expensive biologic. One particular drug is the troublemaker, but I think if you're looking at cumulative growth across the board, absolutely. Melissa.
It struck me on the graph, the line graph year over year, the significant increase in 2016 in Medicare. Is there any context for policy change, or is that just any sense on, is that aging, or is that a new drug on the market, or is that some sort of policy payment change driving that big increase? I don't know if we know, but.
Yeah, Johnny, can you go back to the line graph slide, a couple more back? I don't know that I know definitively and would be willing to commit to any of that. I think if people want to share any thoughts about what that might be, that would be great. I think there are a lot. No, sorry, wrong direction, Johnny. I think if people want to share, I think, yes, there are policy changes. Yes, there are new drugs introduced. All of that is a factor. I don't know that we can pinpoint. There, this one.
Yeah.
Yeah. Zachary, can I put you on the spot? Any commentary?
Yeah. So, I mean, the Hep C drugs for sure came on to the market around that time. I need to do some additional analysis to find out when exactly that hit. That was a big Medicaid driver, cost driver. We can look into it. What else was going on in 14?
Greg.
So I know that, as you said, the amount, the rebates aren't taken into account in this data. I guess I'm wondering if we know just more generally whether there have been any significant changes over the past over this period in the rebate space, like whether they've been on the rise overall and that sort of thing. It seems that they're relevant not only from the standpoint of the fact that the rebates reduce the amount that's ultimately paid in the end, but they also incentivize driving patients toward medications with a higher list price over potentially lower list price items that don't have rebates associated with them, even if the cost, the total cost in the end after rebates is lower, if that makes sense.
Yeah, I think I want to put a pin in that. I think we can provide some more information and summarize some of the information about rebates. I don't want to necessarily derail us too much, so we're not prepared to talk about that. I do want to draw people's attention. There was written public comment submitted from Pharma, and it does reference rebates in that. We'll add the link in the chat, but there is some more information that they've provided as public comment as part of this meeting, if folks haven't had a chance to see that yet. But let's come back to that. Melissa?
Yeah, I just a terminology standpoint, right? There's different kinds of rebates. There's patient rebates, and then there's insurer rebates. And as we're talking through that, it's probably good to be clear on what we're talking.
Yep. And I think that's part of why we just want to recognize it's not here, but we're not ready to fully get into the weeds of how
absolutely
they're applied. So, okay. We provided more of the data behind this. Again, this was a very high level summary, but there is some more detailed data, including the per person spending in each category, subcategory for 13 and 19 in the slides for reference. Please let us know if you have any other questions. Our team is continuing to do pharmacy analysis. We have a number of questions, including things like patient cost sharing and brand versus generic and medical versus retail. So we're going to continue to do this. I expect we will bring back some additional information for you in future meetings, but we did want to sort of close some of this loop with you today. But let's go to the next section of this agenda item. Geronimo, we want to jump to the strategy slides on slide 49. Okay, thanks for bearing with us as we jump back and forth. Almost there. Okay, so as I said, this is a high-level overview of potential policies. Pharmacy costs are complicated. How you address pharmacy costs are also complicated. There are some levers that are more appropriate and are owned at the federal level. There are some that are state-level policies. Some are both. I also want to caveat before we start talking about any of these policies, we are already working on a number of these things in Oregon. Some of these things, other groups, other policymakers, other recommendation advisory bodies have considered and recommended or considered and discarded for various reasons. So I think we're going to present this as a just sort of here's the full menu. But if you have questions or if you want to know more about sort of the history of a particular thing in Oregon, that might be a future conversation. We really mostly want to just set the stage for that. And we want to think about what is within our control as a state. So this is teeing things up for future conversations that we might all have together as a committee, thinking about where are our opportunities to address costs? What are some of these strategies that we might want to recommend? Who are the other groups that are working in this space that we might want to coordinate with? So just a little setting the stage for that. And then finally, next slide, one more disclaimer. Not all of these strategies are applicable to all of the markets. So some things are statewide, some things are going to be Medicaid, Medicare specific. Some things might be more effective in the commercial market. As we just saw, the drivers are a little different in the different markets, and so different strategies might have different impacts. One other example of this, not all strategies work or are appropriate for all markets. There's been some analysis done on states that are looking to leverage international drug pricing, and they found that for most high-cost drugs, international pricing works best in the commercial market because that's where the savings could be the most substantial. But because of how rebates work, that's actually less effective for Medicaid. So again, there's a lot of nuance in terms of which strategies and how they're applied and what Oregon may or may not already be doing. So, okay, I think that hopefully that was sufficient disclaimers getting into what those potential strategies are. So let's start at the federal level. Next slide. There are 4 categories of potential federal strategies: increasing competition, addressing prices, rebates, and then a catch-all, because there's some other interesting things that can happen at the federal level. So let's start with increasing competition on the next slide. So a couple of examples of various federal strategies to increase competition. The FDA has a biosimilar action plan that is meant to spur biosimilar competition in the marketplace through a number of strategies. The FDA is also considering or could consider expediting reviews for generics. There is sole source tracking, prohibiting pay to delay, and better patent oversight. And there's a whole bucket of strategies related to patent oversight and when drugs could enter the market or when drugs come up for review that are all related to this competition bucket. I think, is it easier if I go through all 4 federal strategies and then pause? Okay, I see heads nodding, thanks. All right, next slide. Some of the federal strategies to address prices, including looking at the Medicaid rebate cap, prohibiting pharmacy benefit manager spread pricing, implementing best price requirements, tying price limits to inflation, international reference pricing, so tying how much we're paying to how much other countries are paying, and establishing processes for federal determinations of value of a new drug and then only paying what the drug is valued. And there's a whole bunch of really interesting algorithms and proposals for how some of that would work. Next, some federal strategies for rebates include increasing the minimum rebate amount for certain drugs and requiring rebates for drugs that have significant price increases. So if a drug increases more than a certain % in a year, it would trigger a rebate. Next slide. Some of the other strategies are allowing Medicare negotiation, let's come back to that, allowing importation of drugs, and increasing price transparency. So I started putting all of this together after the July meeting and started to prepare this presentation. And then surprise, next slide, the Inflation Reduction Act passed. And that has really changed the federal landscape and the federal involvement in strategies. So a couple of high level points on this in case folks are not tracking the pharmacy specific parts of it. But the Inflation Reduction Act really changes the Medicare drug price negotiation. So DHHS is now going to be required to regulate and negotiate lower prices for certain drugs for Medicare Part D. So it starts with 10 drugs and then more are added over time. So there's a lot of detail in terms of which drugs are eligible for this, but this is really a game changer because previously it seemed like an obvious strategy. Of course, the federal government should be negotiating for drugs and they weren't able to until the Inflation Reduction Act, which just passed. And so now that federal landscape and the potential federal strategies or linking things up with federal strategies has really changed. And I know there are folks on the call who are more of an expert on this than I am. Does anyone want to provide additional detail or comment on the Inflation Reduction Act and its impact? Oh, sorry, and let's go to the next slide. I totally forgot that I had a second slide on this. So the Inflation Reduction Act also directly addresses Part D cost sharing for drugs. So annual out-of-pocket caps for folks on Medicare, no annual cost sharing over a catastrophic limit, and capping insulin co-payments. There's also implications for Medicare rebates and no cost sharing for adult vaccines. So again, a lot of the proposed strategies or potential federal strategies are really now have been turned on for Medicare Part D. Questions or comments about any of the federal strategies? Anything that people would like to know more about? Marybeth.
Hi. So the pay for delay strategy is under federal strategies, and I know the FTC is going after and pursuing certain cases, but there is a California law as well that authorizes the state attorney general to go after pay for delay. So is it also included under state strategies, or is it just kind of federal from this point?
No, I mean, I think it could absolutely be a state strategy. I don't know that I listed it out specifically here. We'll have to see when we get to the slides if I manage to include it. But I think, yeah, as I said, some of these are both federal and state opportunities.
Great, thanks.
Other questions or comments about federal? Ralph? Yeah.
Hey, Sarah, just to jump in, because I know folks are always interested in what this means to Oregonians, and citing the good folks at the Kaiser Family Foundation, let me just share some numbers with you, what this means for Oregonians. The elimination of the 5% coinsurance above the Part D catastrophic coverage, just over 14,000 Oregonians. The establishment of the $2,000 out-of-pocket spending cap, as opposed to 7,000 being catastrophic, more than 20,000 Oregonians. It expands the income eligibility subsidy for Part D low-income beneficiaries, or subsidies rather, for 5,000 Oregonians, and eliminates cost sharing for adult vaccines covered by Part D by almost 70,000 Oregonians. So meaningful things here on the ground in our state.
Thanks, Ralph. Peter, please.
Ralph, I've been curious about this and I haven't read the Inflation Reduction Act. And one of the pieces was, is this just a cost shift away from member and into either premium or Medicare? Or is this component somehow actually coming out of the pharmacy manufacturers?
I'll be honest, Peter, I have not read the entirety of the CBO's budget analysis on this, so I don't want to get ahead of my skis on that.
And I also don't want to overcommit, but I know that the folks at Brookings have done some really good analysis on sort of the projected impact. I think we'll try to drop that link in the chat about if they anticipate a cost shift from that or not.
I'd really like to see that. It'd be really interesting to think about that as we think about strategies within the state of Oregon.
Great. Okay, let's run through the potential state strategies. Again, pretty quickly, this is a preview. If there are strategies that we're more interested in talking about, we can do that. So again, thinking about these state strategies grouped into a number of categories. We have transparency and affordability review, regulating pharmacy benefit managers, importation and volume purchasing, prices, contracts, rebates, and formulary management, and coupons and cost sharing. I also want to acknowledge, I borrowed a lot of this organization from NASHB and their state pharmacy strategies toolkit. Some of the strategies may fit in multiple categories, and I just put them in categories for the sake of these slides. So I will own any potential mess in that communication. Some of these, is it a price strategy or is it a rebate strategy? There could be some nuance, or you could count it both ways, but I wanted to have some cleaner slides. So my call on that. Okay, looking at the first of the state strategy categories, that is transparency and affordability review. Next slide, please. So some of these strategies include things like requiring supply chain participants to report their profits, net prices, and or rebates. It includes prescription drug affordability boards and prescription drug price transparency programs, both of which we have in Oregon and Ralph will talk about in a few minutes. We're also including some snapshots of the US and how many states have been enacting new laws or new policies in these categories between 2017 and 2021. And again, this is coming from the NASHB state pharmacy policy tracking. So you can sort of get a sense of popularity or trends in some of these policies. Next slide. Regulating pharmacy benefit managers. A lot of states are working in this area. This includes things like banning contract terms that prevent pharmacies from sharing lower cost options, essentially a gag clause where they wouldn't be able to tell a patient that a drug is available more cheaply through another route. Requiring PBM licensing or registration with the state, restricting spread pricing, and more active oversight of pharmacy benefit manager contracting. Oregon had a House bill in 2019 that prohibits pharmacy benefit managers from requiring prescriptions to be filled by a mail order pharmacy as a condition for reimbursement, and also lifted or prohibited the gag clause. So Oregon does have that first strategy in place already. Okay, next slide. importation and volume purchasing. I think probably most people know this as can't we just buy drugs from Canada? So wholesale, this requires some federal approvals. So this is a federal state combo, but this also includes things like volume and consolidated purchasing. There are a number of consolidated purchasing initiatives, including the National Medicaid Pooling Initiative, the Sovereign States Drug Consortium, and the Northwest Prescription Drug Consortium. And we have been part of that work for a long time. There's also subscription models. There's also having states or state purchasers negotiate directly with manufacturers. Because of some of that federal complexity, or because states have already been involved in some of these pooled purchasing arrangements for a long time, there has not actually been a lot of legislative action between 2017 and 21. It's either not happening or it already happened and those agreements are in place prior. Next slide. So prices, directly addressing prices. So a couple of strategy options here include penalizing manufacturers for price increases that are unsupported by clinical data. There's a group called ICER and they do review that sort of ties some of this together, the clinical review, the quality and the value of it. Setting upper payment limits, how much a drug could cost or how much a drug could increase. International reference-based pricing, so saying drugs cost this much in this country, they cannot cost more than that here. Prohibiting price gouging in generic and off-patent drugs, and prohibiting unconscionable price increases. This is a law that was passed in Maryland. And side note, interesting note, as I was digging into this, Maryland's law was actually overturned. Maryland was not deemed to have the authority to prohibit this unconscionable price increase. However, some legal experts and some consultants to states believe that this is still a valid policy option. The bill just needs to be written a little bit different than Maryland's bill. I'm not a lawyer, so I would not get into those details, but this is still a policy strategy that is sort of within a state's toolkit, despite how the Maryland experience played out. Okay, next is coupons and cost sharing. This is another area where there's a lot of activity across the states, most specifically limiting consumer costs for medication. So example, insulin cost sharing is a very popular policy that states have been exploring. Oregon in 2021 capped the total amount that a carrier can require a member to pay for a 30-day or a 90-day supply of insulin. Other strategies here involve allowing or mandating the substitution of lower cost generics when a brand name drug is prescribed, restricting health plans from moving drugs from a lower to a higher cost share tier during a plan year. So between plan years is okay, but not sort of a mid-year shift in prices. And then prohibiting distribution of manufacturer-sponsored coupons when lower cost generic drugs are available. All right, and then finally, our last bucket of potential state strategies, next slide, contracts, rebates, and formulary management. So this is there's a lot in here, but thinking about how the state can act as a purchaser or how other purchasers and payers in the state can collaborate on some of these models. So contracting and value-based payment arrangements that are tied to clinical outcomes. So there are some very specific VBP arrangements for specific drugs that are in place that are an option. Value-based rebates and subscription models, so supplemental rebates depending on the clinical outcome, or caps on spending if a drug is spendier than its value is assessed to be. Also enhanced negotiations for additional rebates for certain drugs, and a single preferred drug list are some common strategies here. Okay, and next slide. Again, as I mentioned, Oregon has a number of these strategies in place already. We have the Prescription Drug Affordability Board and Price Transparency Program. We are part of the Sovereign States Drug Consortium. We also are part of the Array RX Consortium. We have a preferred drug list for Medicaid specifically. We also have medication therapy management programs. If there are questions about what Oregon's already doing for Medicaid, I know we have some of our pharmacy folks on the call who might be able to answer that. But again, just wanted to recognize that we're not coming into this conversation about pharmacy strategies and potential pharmacy strategies with a blank slate. We have enacted a number of policies. The legislature has passed a number of policies already in all of these categories. So there's a lot happening here. Okay. Questions about any of the state-specific strategies or comments about any of the state-specific strategies? Melissa.
I have a lot to say for a Friday afternoon. Sorry.
Great.
The only thing that I guess on those strategies, the one that maybe we have to think about is that upper payment limit. It doesn't actually address the cost limit maybe to procure a drug. And so, we just want, I just think, there has to be thoughtfulness around how do we look at costs into the system, and the procurement component is, because then you can mitigate it to the patient, but that just kind of masks the problem if you limit the upper payment limit of it, right? So thoughtful on that.
Thank you. Any other comments or questions about any of the state level strategies? Okay, Ralph, I'm going to hand it. Oh,
Sarah,
go ahead, Peter.
before you hand it off, I don't know if the Inflation Reduction Act has created a new approach from a legal standpoint. Obviously, the international reference pricing is a real alternative to controlling drug prices rather than sort of coming around the edges of recognizing that drug pricing is unconscionable in certain situations. And we're trying to play around the edges in some places. I think we need a fundamental addressing of our ability to negotiate fair prices within this country. I don't know if there's been a legal analysis since the IRA passed or since the Supreme Court was seated, or at least new justices were seated, what their opinions are. But I think international reference pricing is one of the targets that would really have an impact nationally. That's just my own opinion.
I think as a follow-up, I know there are some really good policy briefs and analyses of what's in the Inflation Reduction Act as it relates to healthcare, and maybe we can share a couple of those with the committee as a follow-up. Okay, next slide has just a bunch of sources and references. I know some of these policies, you're probably not all familiar with all of the various pharmacy strategies. I definitely was not and had to do a lot of reading on this. So here are some of the places that I was reading if anyone is curious and wants to dig in. And now I'm going to hand it over to Ralph. Ralph, you have about 30 minutes. Ralph is the director of the Prescription Drug Affordability Board, and he is going to give us a lot more detail about what's happening in Oregon.
Thank you, Sarah, and thank you so much for spending your Friday afternoon with all of us. Just real quick before we dive in, really from the onset when Sarah opened the meeting, the overwhelming theme I heard from her was that, in one singular word, opportunity. We've got such a great opportunity to start having some really important, data-driven, sustainable, ongoing conversations. The first thing you heard her say this afternoon was, this is going to be a multi-year conversation. This is a long haul effort. So we're really excited about that and just appreciate being able to be with you today to share what we are doing at the Drug Affordability Board and the Drug Pricing Transparency Program. Durande, if you would go to the next slide, please. Thank you. So I'm going to go through this verbatim with you, but need to make some really important points that the Department of Consumer and Business Services believes in the inherent value of the transparency of drug pricing information as a consumer protection agency. It provides a base level understanding of drug costs that quite honestly would be otherwise opaque in the marketplace. A little bit about the program itself to speak to legislative intent. The legislative intent of the Drug Pricing Transparency Program was to provide notice and disclosure of information relating to the cost and pricing of prescription drugs in order to provide accountability for drug pricing going forward. Short version is that much of this work over the last 3 years truly has been pioneering, and we are gathering information on prices and costs as it relates to specific drugs and reported from manufacturers. And Durande, if you would, the next slide, please. Thank you. So this I'm going to kind of go through with you. The program is directed by statute to receive new drug reports from manufacturers that are more than $670 in cost. annual price increase reports of $100 or more, or 10% net yearly increase, 60-day price increase notice when the price is going to go up by 10%, or $10,000 increase for a brand name drug, or 25% and $300 increase for generics. And then, of course, our insurer report, and they report to us the top 25 most costly and prescribed drugs and the impact that those have on premiums. And then, as Sarah noted, we have consumer reporting as well that really tugs on your heartstrings, quite honestly, to hear about some of the challenges that people have, similar to sitting in on a meeting that you all had earlier this summer about hearing about medical debt. These are really difficult things to hear from real people and real Oregonians. Just to give you a flavor of some of the things that we do collect from manufacturers in these reports. So for new drug filings, marketing description, the wholesale acquisition cost, the acronym being WAC, pricing methodology, the estimated average number of patients that use that drug a month, and research and development cost as it relates to the use of public funds, something we find to be very important. A little bit more about the data elements that we ask for in annual price increase filings that are due in March of each year. So for any given NDC, the net increase by percentage, the introductory price, what it was on the first day of the year and the last day of the year, the highest and the lowest spikes in costs that it did hit during that calendar year, dates on the market, justifying explanations of what that increase in pricing decisions were. Again, research and development cost, using public funds, and then some specific pieces around direct cost as it relates to manufacturing, marketing, distribution, and safety and effectiveness, as well as total sales revenue and profit from the drug, and other relevant pricing information, including to some of the reference pricing conversations, non-US prices, 5-year net annual increases, and some reporting around patient assistance programs. Here's where I need to get into some of the legalese and some of the nuances around some of this. The Drug Pricing Transparency Program does not disclose trade secrets. The law provides for conditionally exempting from disclosure information submitted that is determined to be trade secret. With that said, I also need to note that the Oregon Drug Pricing Transparency Program is the subject of ongoing litigation in federal court for the District of Oregon in a case known as Pharma v. Stolfi. The litigation challenges the transparency reporting programs established by House Bill 4005 from 2018 and House Bill 2658 of 2019 on a variety of grounds. It is unclear at this time when a ruling may be issued in this case. Geronde, if you would, the next slide, please. Thank you. So as we mentioned, quite a bit about consumer reporting. This provides consumers a way to report their own prescription drug price increases. We publish that information with their consent on our website, publish manufacturer reported information as we are able to, but except when identified as trade secret. And we gather information from health insurance companies on prescription drugs and provide an analysis of highlights from things that are in our annual report that I will also speak to. Geronde, next slide, if you would. Thank you. So the program is directed by statute to host a public hearing. We'll ask all of you to say the date of December 21st that has already been calendared. A couple things about these hearings, and for anyone interested, our past 3 years hearings are available on our website. Part of this is that we bring third-party experts from Oregon and around the country to surface critical issues around prescription drug costs. We have legislators that have a keen interest in these complex issues and hearing recommendations and what policy levers might be available to address cost. Typically, the hearings themselves are moderated by the director of DCBS, and legislators themselves act as moderators for panel discussion. So very much looking forward to that. Really, the hearing represents an important opportunity for the program to share the findings of these reports as well that we've shared of the annual report that Sarah has spoken to, and some of the detail that I will speak to in my presentation as well. And then really just an important global opportunity to hear and understand different types of issues across the entirety of the pharmaceutical supply chain to better understand how entities influence price to consumers, whether that's at the pharmacy counter, whether it's through health insurance premiums or co-pays, or to that point, as other folks have questioned and contemplated earlier, through the entirety of the healthcare system. So for 2022, we are tracking to do a presentation and discussion on the entirety of the supply chain and PBM rebates and transparency of rebates, in addition to recent developments both through the Inflation Reduction Act and other legislation around insulin pricing and affordability. And then we, of course, provide the deep dive report to the legislature that Sarah has shared and previewed with you as well. Dronde, next slide, please. So just a little bit of preliminary data sampling from 2022. As I mentioned, we're all of about 3 months away from releasing the new report. Year over year, we're seeing much fewer filings from fewer manufacturers of annual price increases. Premature to really offer any speculation or observation about what some of that is. But just a couple other nuggets from the 2021 report, and I'll spare some of those that Sarah shared with you already, but trends show that annual price increases occur less often and they're not as large, but during the same time, it shows that average launch price of brand name drugs have nearly doubled. So significant and of note. And Dronde, if you would, next slide, please. So again, year over year increases in new drug filings. And I'll disclaim, because the specialty drug report is a bit of a misnomer. That is back to what I had mentioned earlier, the $670 threshold as established by Medicare Part D for a course of treatment. So you're seeing that information there, a significant number of filings to date, more than we have previously. Next slide, please. And able to share this information with you all publicly for the first time today. This is carrier reported information. This is a brand new feature to our report this year. We can report these numbers now because of improvements that we've made in our data collection process. Again, this program is 3 years old, so still fairly young on its maturity curve as we learn and grow together and are able to put together new models. But here you're seeing the numbers right in front of you. So roughly $562 million total spend with insurers on a PMPM basis, covering about 85% of that. One of the other pieces that we were able to extrapolate from this is that amongst Oregon's individual and small group health plans, talking about rebates, they received a total of $74,300,000 in rebates and other price concessions for prescription drugs in 2021. That's equivalent to roughly a 13.4% discount from the list or the WAC price. So to the point in some of the discussion earlier about what does the net price look like, again, this is aggregated information, but this starts to paint a picture for you of what the landscape looks like. And Dronde, if you would, the next slide, please. Thank you. So analytic opportunities to inform policy. I actually just want to read this one to you because it's important. We want to identify the most expensive drugs by utilization. We want to show which have the significant price increases and contributed to raised carrier cost and consumer premiums and copays. We want to be able to extrapolate information to identify how rebates and incentives drives cost and impact consumers. Really important premise that we've adopted with our team and all of these programs is the context and the adage, you don't know what you don't know. There is inherent value in understanding the marketplace to develop new policy recommendations and promote accountability and to offer cost containment strategies for both government and private sector purchasers. So lots of great opportunity. Again, the word that Sarah launched this meeting with, opportunity for all of us to do a lot of good work. This is really an exciting opportunity to dive into this data. A lot of this will feed the Drug Affordability Board, which I will speak to shortly. But again, also excited because I think what we're starting to see is a synergy here between some of the data that the Cost Growth Target team generates and the work that we'll be doing. So really stressing the importance of collaboration amongst both of our teams to inform policy. And Dronde, if you would transition to the next slide. I'm going to move on and talk about our Drug Affordability Board. And and just an intro. So entirely new program, very much a work in progress. In fact, Rhonda, if you go on, board had its first meeting the third week in June after being seated by the appointed by the governor and confirmed by the Senate literally that very same week. We'll just share a little bit more about you, and don't need to read this to you verbatim, but giving you that context. So the board itself won't be fully seated and staffed until late September. We had 2 vacancies on that, and we're excited to announce that those 2 folks were appointed by the governor just in the last couple of weeks, and we'll go through Senate confirmation hearings later this month. Also, we'll note that we put a real priority on doing a targeted rural recruitment to ensure that we have good rural Oregon representation on this board. To that point, we'll have representation from Southern Oregon and Grants Pass and from Eastern Oregon out in the Hefner-Boardman area. And again, folks that have clinical backgrounds in medicine or healthcare economics. So very excited about that itself. Want to just read to you again, talked about kind of legislative charge and mandate. Simply put, to protect residents of this state, the state, local governments, commercial health plans, healthcare providers, pharmacies licensed in the state, and other stakeholders within the healthcare system in the state from the high cost of prescription drugs. Again, brand new program, very much a work in progress. Starting to look at what the alignment looks like between the drug pricing transparency program and the board itself. And to that point, the board itself, it's important to note, I think, so the drug pricing transparency program, we went through and talked about some of the pieces with you, and those are kind of threshold reporting triggers, if you will, whether it be product launches, price increases, et cetera. Board has a very different mandate to look broadly at the system and to make broad policy recommendations and to conduct affordability reviews, which I will speak to shortly. And Geronde, if you would go to the next slide, please. Thank you. So prime responsibilities of the board itself, affordability reviews, which I will speak to that very shortly, and to set a manufacturer street fee structure for the program. The legislature did provide seed money for the program. It is, as many programs at DCBS are fee-based as sustainable and will not be supported for the long haul by state general fund. And then annual reporting requirements, we have several, and that is a generic marketplace study that will be due to the legislature, and similarly report to the legislature and the cost growth target program itself called out by statute that identifies price trends, the drugs that we've identified for affordability reviews, and recommendations to make drugs more affordable. So again, we are just beginning to learn. None of these things, as the cost growth folks know, you know, none of this data, none of this information comes pre-wrapped. It doesn't have a bow on it. Pulling from multiple data sources, very excited about all those opportunities. And we really are embracing a lot of the uncertainty that comes with what we will be doing in recognition. As I said, we don't know what we don't know, and we will identify those blind spots as we go, and we will figure those out. Analogous, I'll ask everyone just kind of look at our logo that we love, our branding down at the bottom of the mountains. And metaphorically speaking, we are crossing a mountain range that has an unimproved trail, and we know there's something important on the other side, and we will get there. When I say unimproved trail, I need to say that in the context and recognize some of the states that have gone ahead of us that Sarah shared on that slide, specifically the folks in Colorado and Maryland who have been so very gracious with their time and support and the work that they've done and helping us on our maturation curve as well. So we are very fortunate to be able to get their support as well. Geronde, if you would, next slide, please. So mention these drug affordability reviews. The board itself is tasked with identifying 9 drugs and at least 1 insulin product that may create affordability challenges for the healthcare system, high out-of-pocket costs for patients on the criteria based on those adopted by the board, and that will be memorialized in rule. I need to say, and should say it many times, that at the heart of this, the board itself considers drug affordability to be a health equity issue. That is one of our North Stars, and we will not be deterred from that. And as as mentioned, we'll study the entirety of the system and around the world for that matter and make recommendations to the legislature itself. Dronde, if you would, next slide, please. So context and spirit for these criteria, as I mentioned, we will go through a rulemaking process. We will have the board develop and review these based on data and go through a rulemaking process in calendar year 2023. Short though, really cost as an access issue for communities of color. Again, commitment by the governor's office to help eliminate health inequities by the year 2030. Number of residents in Oregon prescribe the drug, prices they're sold, average monetary concessions to insurance plans, estimated total price concessions, discounts, or rebates manufacturers give pharmacy benefit managers, and for that matter, the estimated price of therapeutic alternatives. And before I ask Dronde to go to the next slide, I will say I jokingly said none of this stuff comes with a bow on it in a box. None of it even comes in the same box. These are disparate data sets from multiple different places and some commercially available data sources and other publicly available data sources. So as we, again, grow as a team and our analytic capacity, these are the kinds of things that we will be peeling back and looking at, all in a very transparent way. Our board meets once a month. You will see information at the end of the presentation on how to register for updates and some good, interesting information about upcoming meetings. Dronde, if you would, please. Thank you. So continuing with this, and this is the deep dive, folks. This average price concessions, discounts, or rebates from manufacturers, the plans or PBMs for therapeutic alternatives. There was conversation earlier in the meeting about net of rebate is when a brand product is less than a generic, what kind of perverse incentive does that set in formulary development? So all those different things we'll be looking at. Estimated cost to insurance plans, impact on patient access, very important financial impact on the health, medical, and social service as cost compared to therapeutic alternatives. And when we talk about those financial impacts, we're talking about the same frontline healthcare professionals that could be working at our safety net clinics that but for opportunities and savings around, acquiring drugs through 340B programs or other programs might not be able to stay fully staffed or even keep doors open to provide, primary care in those settings. So we'll be looking at patient copay and assistance and other cost sharing programs and other things or pieces of information as determined by the board. If you would, Dronde, next slide. So again, part of the charge is to study the entire prescription drug system. So we will be looking at everything from establishing upper payment limits. And there was a comment or question about some of the uncertainty around that earlier. One of the things that we've seen from our counterparts in Maryland and Colorado as they build out some of those models is the importance of recognizing a carrier use of savings report. So if there's going to be a price ceiling on any given drug, how is that savings reflected? Is it being used to lower premiums? Is it being used to lower copays? Or is it going towards the C-suites? So these are the kinds of difficult conversations and issues that will occur in conversation. Again, very open, very transparent process, and share a little bit more with you about that shortly. But specifically mandated to also look at reverse auction marketplace, which is really a phenomenon of a pharmacy benefits manager, not about drug purchasing. Sometimes there's a little confusion there. And then exploring bulk purchasing opportunities for state and local governments. And to that point, a lot of this work has been done already. And we'll speak to that. Sarah had mentioned that there has been a lot of work done in terms of recommendations from past task forces. The interim task force that was led by Rep. Nose at the time. We have 3 years of recommendations of history from the Drug Pricing Transparency Program. So lots to draw on. Also need to recognize and say publicly that our board that is new and not fully seated, our staff that joined just over the summer, our data analyst that's actually coming on board next week. We're actually trying to do 12 calendar months worth of work in just about 4 months or less. So figuring out what that sweet spot and balance is and producing quality work and product and important recommendations to the legislature, but also wanting to be smart about it given the short amount of time that we have. And Dronde, if you would go to the next slide, please. Thank you. So a couple slides that I will move through fairly briefly, really, again, noting we had our first meeting just earlier this summer. Folks will see where you're able to join and participate and watch if interested, but just our timeline. So we're doing a presentation of the board, the first draft on September 21st, and that is not a draft, that is more a topical conversation about work that board members have been doing to help build out the report. But there will be a presentation of a final draft report as we get into October and November. That left side covers the required deliverables as defined by statute. And Geronde, if you would, next slide, please. Again, next couple slides, we'll just move through these fairly quickly in the interest of time, but our own roadmap for the deliverables, again, late start in the calendar year to do this. The board itself will be getting the information from the drug pricing transparency program, and we will start looking at and analyzing what some of the data is in preparations for developing draft rules, both around the affordability review criteria and fee structure. It is important to note on the affordability reviews themselves that, again, I think spirit and intent, purpose of those for states that did get the enabling legislation to do upper payment limits was that those 9 drugs and insulin product would actually be the drugs for which that ceiling is set. Again, as Sarah noted, we do not have that statutory authority, but again, in my slides, you noted, and I think came up in earlier discussion, one of the board's prime charges is to make recommendations to the legislature. The list of things that Sarah shared from that NASHP slide, amongst other policy levers, are all things that the board will consider in packaging and recommendations. And again, all of those will happen in a public and transparent meeting forum that we encourage and welcome everyone to watch and attend. Geronde, if you would, next slide, please. And I think we can just move through this. Again, this is just longer term, looking at when we really actually have a full calendar year to do a year's worth of work and what that cadence will look like. Geronde, next slide, please. Thank you. So a little shameless promotion here for our program. Would love all of you or anyone that is interested to sign up at the link from our website down below. But our next meeting on September 1st, we've got Trevor Douglas from OHA, the Director of Pharmacy Purchasing, coming to speak about Medicaid drug rebates, preferred drug list development, and Array RX. And very pleased to announce, so we had, and these are all board member requested presentations, I should note, a presentation on prescription drug patent law. I'm really pleased to announce, and we've just secured this presentation just in the last 48 hours, a gentleman named Tahir Amin. He is the co-founder and executive director of IMAC, which is an internationally recognized group as an expert on prescription drug patent law with a focus on health equity. So super excited about that. Encourage folks to sign up to participate and watch. And then again, questions about upper payment limits came up earlier, even in this conversation. October 19th, we have presentations from the executive directors of both the Colorado and the Maryland programs, where they are in their arc of implementation and development of rules around upper payment limits. So lots of good conversations ahead. Hopefully there are things that you will watch and learn from, as we all will together. And really, end of conversation or presentation rather. Fairly limited. I don't know what our timing is. Happy to take some questions, but folks, please don't take offense if they're related to the transparency program, and my canned response is due to pending litigation, I'm unable to respond.
Ralph, I think I'm going to jump in for a second, and I want to talk about, I want to frame a couple of options for the committee, and then I want to open it up for discussion and questions for you, because I think they're going to be related. Johnny, let's go ahead. One more slide. So I think for the committee, we just gave you a whole lot of information on a Friday afternoon, so thank you for bearing with us. And I think we want to talk briefly about where do we go next. There is a lot of information coming out, as Ralph was talking about, in the next couple of PDAB meetings. The Prescription Drug Price Transparency Program's annual report and public hearing is coming in December. The annual report with recommendations, some additional analysis that our team is doing. There's going to be a lot of information additionally about potential strategies and opportunities between now and the end of the year. So I think we wanted to pose to you today and get a gut check on, do you want to continue a conversation about pharmacy costs, pharmacy strategy in November? We could potentially go deeper on any one of these topics or strategies in the November meeting, or we could wait and come back in 2023 and hear again from the board, hear what those recommended strategies are, and then think about what, as the cost growth target committee, what strategies you might want to endorse, what other opportunities there are, what that alignment looks like. So I think I'm saying, are there questions or discussion that we'd want to continue having in November? Are there questions for Ralph in the short term? Are you okay if we hold this for an early 2023 conversation when we can see what some of those recommendations that we know are coming and those recommended strategies will be? Or do you want to keep going in November? Let me stop there. Peter, please.
First, I'd like to thank Ralph for his work on this board. What important effort, and thank you for that. It sounds like it makes an awful lot of sense, since there's so much work going on at the Prescription Drug Affordability Board to get their information back to our committee, so we don't sort of develop two lines of thinking, but certainly open to other comments or other thoughts.
Thanks. Mary Beth.
I would agree. I think that the timeline that the board is on, which is doing, I think, some really incredible work that and will come out with some really useful information for this committee, won't be ready for our November meeting. So I think postponing until early 2023 would probably be a good idea.
Thank you for that. I saw a couple heads nodding when both Mary Beth and Peter were talking. So I think we might have agreement that we won't necessarily come back. We'll wait until after the December reports and hearings are out and then revisit this next year. So with that, I think, are there questions for Ralph about anything he presented? Are there questions about any of the specific strategies that people would like to learn more about and we could push some information? Is there any more detail that would be helpful? I think let's do Melissa and then Stefan.
Yeah, I also want to say thank you, Ralph, for your presentation. I have not seen much of this, and so really informative and appreciate. I have maybe what's a silly question, but have there ever been the strategies discussed around limiting drug advertising, or restricting that in the state as a strategy? I know that's
I don't believe there has, but I will share that there is an adage amongst some of the state Medicaid pharmacy folks, and that is that if it's on TV, it's on PA, meaning if it's on television, it's on prior authorization. But beyond that, I'm not aware of any conversations in that regard.
Okay. Thank you.
And sorry, we also have Trevor Douglas from OHA's pharmacy program. Trevor, is there any context or history on drug advertising strategies?
No, I won't add anything further than what Ralph already did. I think that captures the sentiment that many of my colleagues across the country share. Yeah.
Thank you. Stefan.
Yeah, thank you. Just to clarify a question, one thing is, are you considering cost effectiveness for your review of these drugs? This is something which is very common in Europe to assess whether a drug should be included in a plan. And the second one is, you mentioned these recommendations, and it's always recommendations for the list. So I was just wondering, I was just for those 9 drugs that you identify, or these recommendations more broadly for all drugs?
So 2 great questions, and thank you. So first, I'm excited to tell you that our team just had a presentation from ICER this morning, and I note that that was referenced earlier in the presentation, and that we are actively working. In fact, one of our staff is probably doing it right now to do the contracting necessary to get that kind of evidence-based source. I'll also note, though, because I think this is an important thing to flag, is that the use of QALYs, and that our legislation specifically prohibits us from using QALYs. And that was part of that candid conversation this morning, that they have another benchmark, and forgive me, I can't recall the evidence-based acronym, that is an analog to QALYs, but has some other factors involved. So yes, certainly looking at the evidence-based pieces will be a part of that. And then to your point about utilization, back to the recommendation piece. I need to disclaim, while I'm the executive director of the board, I am not the board. The board has procedural voting processes in place and will do so. But in the context of recommendations, I think one of the recommendations the board may contemplate, and this is really evident, I think, in some of Sarah's slides, that there are a lot of really expensive drugs, but have very narrow utilization, broadly speaking, to the entire population of the state. So if there are other drugs or classes that should possibly be looked at that are lower dollar thresholds, but massive utilization, then potentially should the board be making a recommendation to the legislature to give itself authority to look in that direction?
But so if I may just follow up, and so it's late, my brain might not be as quick or anything, but like we just had some sort of a conversation around, I think Peter, you made this really good point a while ago, but like, you know, when you look at this bubble graph, like every bubble is a problem, right? So they're all way above our kind of cost curve target. So the answer is really like, you know, this is not about 9 drugs or 18 drugs or 25 drugs. This is like a systemic issue, right? That is across all drugs.
Right.
So I just want to connect those two, right? It's
Sure.
like, I think like if that's kind of like my one takeaway point from, you know, that kind of analysis. And I think like if that can be carried through in your work, that'd be, I think, great.
Well, thank you. And I think we're on the same page there. And I would just note back to some of the Medicare pieces. Look, the Medicare negotiation that, you know, Part D started 2003, 2005-ish. Don't hold me on that. Here we are 18, 19, 20 some years later. Congress just gave the federal government authority to negotiate over a universe of drugs that's about this big, not this big. We in our enabling legislation are to study 9 drugs, and again, disclaiming, caveating, we do not have authority to set upper payment limits on them. But in the glass half full mindset that we all have to have about this is that this is the opportunity to start the conversation. And yes, it might start with 9 drugs. It has to start with something. Over time, hopefully that will grow.
And I want to add on to, I think, what Stefan's saying about bridging this work together. So Ralph's programs and board will be sharing information with the cost growth target program, statutorily required to do so. So there is an information exchange, and I think there'll be a real opportunity to say, okay, currently they were only able to recommend upper payment limits here, but here's the rest of the gap. What can the cost growth target committee recommend? Does the cost growth target committee want to recommend something? This committee does not have the same statutory limitation. It also doesn't have the same statutory charge. So there's sort of a gray area here. But I think if we're all looking at what are the cost drivers and what are those strategies and opportunities to address those cost drivers, that is well within the scope of this committee. And I think that's part of why we want to keep these bodies of work really closely connected and continue to explore. Just because PDAB might have some limitations, we might be able to carry the conversation further, or vice versa. I don't know where that could go, but I think we want to maintain that bridge. Yeah, Stefan, please keep going.
So yes, thank you. That's really helpful. Just to clarify, so is this correct that you have a statutory limitation to just study with 9 drugs? Prescription drug affordable board, right? This is what we're talking about.
Yeah, so 9 drugs and 1 insulin product.
Right. So that's your limitation for, okay, so you're tasked to do just that. Because I looked for this, I looked for this and it says, you know, where did I see this? Function was studying the entire prescription drug distribution and payment system around the world. But this is only when with respect to these 9 drugs plus insulin.
No, sorry for that confusion. So to delineate, that is a recommendation report. If we can distinguish between the affordability reviews being one discrete deliverable, if you will, and then the study of the supply chain being a separate discrete deliverable, and what other purchasers, both domestically and internationally, are doing. They're discrete deliverables. But I think the other thing I want to flag, and Stefan, happy to have you continue with this, but is that in addition to the opportunities, I think Sarah was alluding to this, is we're going to identify what the gaps in data are. And what our team has and knows, and what Sarah's team has and knows, and the opportunities that we're able to share with statutory authority. Let me be certain to say that part out loud, and to identify where there are those voids, and then potentially for the cost growth target program or the policy board itself and or the board, the drug affordability board, to make recommendations to the legislature to amend statute to be able to share data as needed.
Thanks. I want to move us to public comment on time, but I want to make one more connection here. So there's the scope of authority and the charge that the Prescription Drug Affordability Board has in the Prescription Drug Transparency Program. There's our scope and charge as the Cost Growth Target Committee, and there's the Oregon Health Policy Board. The Cost Growth Target Committee, we can make recommendations to the Oregon Health Policy Board. The Oregon Health Policy Board healthcare costs and cost containment, cost growth target is one of their 4 priority areas. And so there's a whole other avenue here of additional strategies and conversations that can run up through the Oregon Health Policy Board. And I'm going to ask Bill Kramer as our policy board liaison. He's still on. Bill, can I put you on the spot? Do you have any commentary? Do you have any connections that you would want to draw through any of this?
Thanks, Sarah. I will say this is just a tremendous presentation. There's an enormous amount of information here, and I think it is complex to figure out how the state could take action that would affect, particularly to affect commercial prices. There are things that can be, and of course Medicare. There are things that can be done in certainly in Medicaid and perhaps in the state employees program that will be very helpful. I also appreciate Ralph's work on the transparency program. Having the data is really essential. One area I also flag is something that some other states have attempted, and Oregon has made some attempts as well, is to look under the hood on PBMs because there's just a lot that is unknown about what PBMs do in terms of the flow of money, how they structure their formularies, that I think we need to understand better in order to get our handle on costs. The root cause, of course, is still what drug manufacturers are doing, but PBMs play a role too that affects the ultimate affordability for employers, for the state, and of course for consumers and patients. By the way, I'll say all the ideas that people raised here about whether it's dealing with direct consumer advertising, the importance of comparative effectiveness research. Really glad that Ralph and his team have made connections with ICER, and also Tahir Amin at IMAC. He and his organization are tremendous. Now they're tackling federal patent laws particularly, so I'm not sure there's that's mostly at the federal level, but having an understanding of what the impact of the patent law abuse has been can be very helpful to the work we're doing here in Oregon. So I really appreciate today's presentation and the questions and the discussion as we wade into this. This is going to be a toughie, but it's important.
Thanks. Well, all right. Thank you again, Ralph, so much for presenting. I know we'll be inviting you back to talk to the Cost Growth Committee in the future. I think we will schedule something, probably our first meeting in 2023. I think we're aiming to have that in February. And that seems like it would be a good time to hear what the sort of reporting out from these programs has been, and check back in then. I think I would encourage all committee members, if you have questions or follow up about any of the specific strategies, any of the data, anything that was in the slides that I presented or that Ralph presented, please send us an email and we'll do some follow up. We might push some more information back out in November just to help answer questions or connect any dots, but we'll plan on a more detailed conversation then. So thank you. And let's switch to public comment, which is all about pharmacy as well. So I want to draw your attention. We had 2 written comment documents submitted. They are both on the website. One is from Pharma, and we linked to that earlier. I'll drop the link again in the chat. And the second is from David Ladwig. David, I believe you also wanted to speak to your comments. So if you are still here and ready, you are up.
I'm here. And 4:45 on Friday afternoon. Thank you for people that are still here. I spent 5 of my last 16 years working with retail pharmacy, in specialty pharmacy. So I think I'm fairly expert in some of the data nuances. But I put together that PowerPoint presentation in response about a year ago when pharma was fighting the prospect of the enabling legislation for Oregon. They were fighting that, and they were fighting it with the same messaging that they've been using to fight against any change in pharmacy pricing at the federal level. Pharma's not our friend. I don't know what the pharma response is, but I encourage you to look through my PowerPoint there. I think I took great care to have reliable, verifiable links on each of the pages. They're making a lot of money. As an industry, they are making like 2% more than other industries with comparable risk research profiles. So yeah, I encourage you to look at my PowerPoint.
Thank you for sharing. I added the link to David's PowerPoint and to the pharma submitted comments in the chat. They're also on our website. Is there anyone else who would like to submit public comment today? All right, I'm not hearing or seeing any hands. Okay, Peter, I think we are ready to wrap up. Let's just go to the last slide with a reminder about our November meeting. And then if you want to give us any closing comments at the end of the day on Friday, that would be great. Johnny, all the way to the end, please. So just a reminder that we moved our November meeting date. It was originally November 9th and it is now November 22nd. It is at 9 a.m. So we will not be meeting again late on Friday afternoon. I think we all can appreciate that. We do want to focus on our plan for 2023. We also want to talk about accountability. So what happens for payers and provider organizations who do not meet the cost growth target in the future? So that'll be the meat of our conversation in November. We might also have some follow-up analyses and questions that we come back to, but mostly I think we're going to be talking about accountability. So just a preview on that. And again, thank you all so much for sticking with us on a Friday afternoon. Really appreciate everyone's comments and participation. And Peter, you have the last word.
You bet. Thank you. I would echo the thanks for hanging in there on a Friday afternoon. I would also note that Sarah, you and your team and Ralph's report were really responsive to some of the questions that came up at the last meeting. It makes it really fulfilling. I really appreciate the information that was provided. We have an extraordinary amount of work to do to think through the way that we view the 3.4% cost growth target, future decreases in that, in light of some of the challenges that we have. Sarah and I talked at length about how we need to start thinking about these cost growth targets in phases over time periods, as opposed to sort of annual measures exclusively. So the annual measures give us an idea of what we need to work on, but the real opportunity here is to think about how do we create long-term solutions to price inflation that our state and its members just can't afford. So thank you very much. And I'll look forward to working with you all as we go forward. We are adjourned.
Thanks so much, everybody. Have a great weekend.